I'm biased towards her, but she's a very good assistant lecturer in your beautiful department. She will talk to us about the role of dynamic MRI in the improvement of diagnostic accuracy in lumbar degenerative diseases. دكتور نيرة تفضلي.
السلام عليكم. Good afternoon, my dear professors and colleagues. Today I'm going to talk about a very powerful research tool in the musculoskeletal imaging, which is dynamic positional MRI of the lumbosacral spine. First, I would like to thank my great supervisors, Professor Dr. Abdel Fattah Saoud, Professor Dr. Yasin, and Dr. Muhammad Yusri. And special thanks to Professor Dr. Hussam Saer for his unique reports. It was really a great guide for me. These are our learning points. So what is dynamic imaging of the spine? MRI is the gold standard imaging modality for symptomatic degenerative spine. It helps to assess soft tissue-bone relationship to try to elicit causes of neural compression. Dynamic MRI is the assessment of spine in different positions, flexion and extension, either during weight bearing or non-weight bearing, which allows better assessment of dynamic spinal instability and simulate reality as per patient's activities. The functional spine unit represents the smallest motion segment of the spine and exhibits biomechanical characteristics like the rest of the spine. Approximately 70% of the workload is carried by the vertebral bodies and the intervertebral discs, with the remaining 30% of the load being distributed through the facet joints. Degenerative disease of the spine is a definition that includes gradual loss of normal structure and function of the spinal unit. Spinal instability can be defined as the loss of the ability of the spine under physiological loads to maintain its normal alignment. Degenerative spondylolisthesis is a definition as the excessive translation of one vertebra over another due to degenerative changes of the supporting structures. It can be static or dynamic, presenting only on positional changes. So what's new? Until a few years ago, X-ray was the only imaging modality for the spine in the dynamic context. Conventional MRI examination of the spine usually are performed in supine position. In functional rest, this can result in negative findings, even in the presence of symptoms. To be optimum, kinetic MRI is done in upright flexion and extension, but here we do flexion and extension when results are negative and when surgery is planned. Our technique: all patients were subjected to history taking and conventional MRI, then lumbar flexion and extension MRI image sequences were obtained for each subject in the supine position. Lumbar extension was achieved using roll towels to achieve a comfortable tolerated maximum lordosis, as here in picture A, while flexion was maintained with bellows to flex the knees and hips, as in picture B. Then T1 and T2 sagittal and axial, then T2 sagittal in flexion and extension sequences were taken. The used machine here for this technique is Siemens Magnetum Sola, which has a wide door with diameter of 70 centimeters, allowing us to modify the patient's position in flexion and extension. I'm going to spotlight on the most important morphometric parameters in dynamic MRI that made it superior than traditional flexion and extension radiographs. First, the ability to measure epi diameter of the dural sac at the disc level in different positions. It is measured between the posterior surface of the disc and the interspinous ligament, excluding the posterior epidural fat. According to previous MRI-based studies, if it's below 12 mm, spinal stenosis should be considered. Foraminal height and foraminal area were also measured, searching for any significant positional narrowing. Foraminal height was measured as the longest distance between the border of the superior and inferior pedicle. Based on previous studies done, a height less than 15 mm were associated with significant nerve root compression and indicate foraminal stenosis. Foraminal area is drawn anatomically according to the foraminal bony outline based on previous cadaveric studies. Reported average foraminal area ranging from 40 to 160 cubic millimeters. These are the results of paper done at Ain Shams University Hospital accepted for publication. The percentage of patients with explained clinical picture that affected decision making through dynamic MRI after failure of conventional MRI to explain it were 54% of the cases. Unstable levels that coincided with the clinical findings were all subjected to surgery, while unstable levels that was not coinciding with the symptomatic levels were always put under close follow-up as potential source of adjacent segment disease. I would like to present some of our cases. First, a 73-year-old male patient with history of L3, L4, and L5 fixation presented with low back pain radiating to left lower limb of 2-month duration. His clinical manifestation was correlated to the level above fixation. The orthopedic surgeon was suspecting adjacent segment disease, and our study showed the following. Here is the mid-sagittal T2 images of the 3 positions, and now let's see some zoomed images. As we can see here on flexion images, L2 is displaced backward over L3, denoting instability in flexion, compressing the dural sac, which is seen measuring 0.7 in AP diameter in flexion, while measuring 1.1 centimeter in neutral and 1 centimeter in extension. Upon follow-up, the recommended management for this patient was fixation surgery. Unfortunately, he wasn't compliant and his pain level was worsened. Another case is a 45-year-old female patient with history of lumbar fixation. 9 years ago, presented with left leg weakness and paresthesia of 1-month duration. Here is the mid-sagittal T2 images of the 3 positions, and now let's see some zoomed images. We can see evidence of spinal instability as shown by more forward displacement of L5 over S1 vertebra. Upon measuring the vertebral end plate, it was about 30 millimeters. So the distance of displacement is more evident at flexion position, measuring about 9 millimeters, while measuring about 5 millimeters only in neutral position. Also in this case, the recommended management was fixation surgery. She wasn't compliant and her pain level was worsened upon follow-up. Our last case is a 40-year-old female patient presented with low back pain and bilateral sciatica, more on the left side. Here is the mid-sagittal T2 images in the 3 positions. As we can see here, there is more affection of L4, L5 left neural exit foramina on flexion and extension than in neutral position, with neural foraminal height measuring about 1.6 centimeter in neutral, while measuring about 1.3 centimeter in flexion and extension position. To sum up, dynamic MRI is the imaging modality of choice in assessment of spinal instability and degenerative changes. Pathologic findings can be masked in neutral position and revealed in flexion and extension. New technologies and the state of art of the MRI machines provide a better experience for patients and clinicians. Our study found added value of dynamic MRI in about 54% of the cases. Interestingly, our study found that foraminal height is a stronger indicator to rely upon in positional MRI compared to foraminal area and dural sac diameter in cases of clinical radiological mismatch by neutral MRI, but of course, this is for future studies. Our take-home message, dynamic positional MRI is useful in cases where there is mismatch between conventional MRI and the clinical manifestations by revealing the hidden pathologies, explaining the symptoms of patients, leading to better clinical outcome. Thank you.
بشكر الدكتورة نيرة على البرزنتيشن بتاعها، وبدعو الدكتور يحيى سعد والدكتورة سارة رأفت عشان يقدموا interesting cases